Okay, first question. Once you label me, you negate me. What about accepting the reality of the TBI so you can move forward?
I think that you have to recognize the TBI. That's very important. And more important than the TBI is what specific effects a person may be experiencing neurologically, medically, metabolically, socially, and resources. Those are all important things, but that's not the totality of the person. And I think that the emphasis of that quote of once you label me, you negate me, is if that's all you look at in the person, if that's all you recognize the person as, then you're taking away their humanity, you're taking away their other assets as well, and you're not recognizing their capacity. Just really quick, I was working with somebody once, and I'm an airplane freak. And we're at lunch and talking about some stuff, and she starts to rattle off the flight characteristics of a Boeing 707 airliner. And I'm thinking, wow, you know, and I had objectified her, you know, she was in her 50s and she had had a brain tumor resected. And so I said, gee, that's interesting. Well, how do you know all that? And she said, I used to be a flight attendant for Pan Am. I used to do the international flights. Oh, really? Yeah. Well, where'd you fly? A lot of times London to New York. And we're talking a little bit more. And she wasn't boasting. She says, as a matter of fact, there was a day in February of 1964. And we had 4 nervous musicians in first class who were coming over to play on the Ed Sullivan Show. She brought the Beatles to America. And so that's what I mean. I respect all the things and the issues, and you have to be honest, you have to be open. It's not a matter of shaming or judging, but you have to see the full person, because if all you do is see the brain injury or the deficits, you're not going to get anywhere.
Okay, the next question is for Bud. Can you go over how epilepsy impacts TBI?
We have to look at it from 2 perspectives. If it's epilepsy premorbidly, meaning before the brain injury, then we're dealing with a situation where there is a short circuit going on in the brain and it's affecting an individual's life, with hope that they have received appropriate medical care and that they're on medications and that it is controlled as it can be. A person with a brain injury, on the other hand, the epilepsy, or the seizure activity, as we would call it, is caused by the brain injury itself. It's a result of the brain injury. It requires the same type of medical care. In other words, a neurologist would need to diagnose, would need to evaluate, would need to prescribe appropriate medications, and with the hope that they would be able to control the seizure activity. The problem with seizure activity is that with each seizure there is a certain amount of impact on the brain, and it can continue to cause deterioration. And if that's the case, you will see in the individual's presentation a certain amount of cognitive loss, physical loss, and so forth. So the key is to get it as balanced as possible, as managed as possible, appropriate level of medication, not too much, not too little, with very regular medical visits.
I'd like to add just a little footnote to that, because I have experience. My son developed seizure activity, and sometimes late onset seizure activity kind of fools you as problematic behavior. And my son was progressing very nicely until like 3.5 years post-injury, and then we had some severe changes in behavior, and he started complaining about, he'd get in my car and he'd say, "Who's been smoking?" And nobody ever smoked in my car. And that's a tip-off. I mean, when you have olfactory changes, hallucinations, kind of spacing out, that's a good time, if you see things like that, to have somebody evaluated. Do an EEG and find out if you're having any problems with late development of seizures. This is a good one. How often is brain injury, minor traumatic brain injury, even concussion, misdiagnosed as mental illness? When the misdiagnosis is discovered, what steps would you recommend to start the rehabilitation process?
The issue of mild traumatic brain injury and concussion is getting a lot of attention these days. Well, first of all, it's the most frequent form of traumatic brain injury. So of the 1.7 million people per year who are diagnosed with traumatic brain injury, I think something up to maybe 1.3 million of those are people with mild traumatic brain injury. And the clinical definition of a mild traumatic brain injury is anything from an alteration of consciousness to a lack of consciousness or loss of consciousness, a coma that lasts 30 minutes or less. So that alteration can be that somebody becomes dazed or confused. They may not remember the event, but they're still walking around, to somebody who has lost consciousness for up to 30 minutes. And then there's other categories of complicated mild TBI, whether or not there's something in neurological studies and things like that, but let's just stick with the basic definition. A lot of times, there are a lot of other people who have had concussions or mild traumatic brain injury that are never diagnosed because they never go and see a professional. So maybe they have, their bell is rung if they're playing sports, or maybe, something happens and they just don't go see somebody. The data says that the majority of people who have sustained or experienced a concussion or a mild traumatic brain injury tend to recover most of their function within about 3 months or so. And that can be maybe 80%, 90% of all people so identified. But there's a group of people between 10 and 20% who seem to have continuing problems. And it's not necessarily the severity of the concussion or mild traumatic brain injury, so that doesn't mean that if you were knocked out for 29 minutes, you're going to be worse off than if you were just fuzzy for a while and you're a little bit confused and disoriented. And Ronald Ruff, a very prominent neuropsychologist in California, has talked about this group as being the miserable minority, this 10 or 20%. Not that they're miserable people, but they continue to have these problems, even though the majority don't. Diagnosing a mild traumatic brain injury, again, you can just say, okay, well, this person was knocked out for a few minutes and that stuff, they had it. But diagnosing the effects is very complicated because it seems that there can be a number of factors going on. Sometimes for those people who don't get diagnosed and then they show up in health or mental health systems later, maybe a year or two later, because they're agitated or they're depressed or they're having problems with sleep and things like that. If that history of concussion isn't noted, maybe the person doesn't think about it much themselves either. I got hit by a golf ball playing golf, it hurt a little bit, Bob bought me a drink and we're fine now and we're friends, and doesn't even realize it. So if the physician, psychiatrist, or whoever is doing the diagnosis doesn't know this past history or etiology of a concussion, then they're not going to put that in the formulary. And they may say, oh, you must be depressed, or this is a stress disorder, or something like that. Sometimes a person might have had a concussion, but there may be other underlying events. So maybe they do have a history of psychiatric problems, or they might have what I call subliminal psychiatric problems, which is just the nature of their personality or something may be such that they may be prone to be fidgety, or they may be prone to be a curmudgeon or an anxious type person, and those types of things might be developing. Sometimes it's a combination of the two. Heaven help me if I ever have a brain injury, or heaven help the world, I should say. But so a person may have some of these low-level characteristics that they can manage. They tend to be a bit agitated or an acerbic personality, but they know how to hold their tongue and stuff like that, and it really doesn't affect people. But then from having a concussion, they also have neurological issues, so that maybe they become a little bit more impulsive, maybe they become less socially aware of how they behave or they interact, and so these two come together to cause the problem. So you really have to identify these things and diagnose these things. So if you've been diagnosed with a mental health issue and you think that there's some issues going on with the concussion, you may want to seek another opinion. The most important thing is a very careful and articulate assessment. It might start with a neuropsychologist, it might start with a neuropsychiatrist, it might start with a neurologist who really understands not only brain injury, because most neurologists, ironically, don't work with traumatic brain injury as much as other issues, but also understands all these vagaries of concussion or mild TBI, because you might get misdiagnosed again. If someone gives you a checklist and says, here's 22 things that might be related to concussion, how many of these do you have? And that's all you do. Well, it might show that, you meet a number of these criteria, but I need to know. I need to know about your past history. I need to know about your family history. For example, for psychiatric issues, some things tend to follow family patterns. For example, schizophrenia. If there's schizophrenia in your family, they're more likely. Depression and these things. So it's something that needs to be articulated. And especially with a mild traumatic brain injury, if somebody gets knocked out, don't say, oh, well, call me in 3 months and 1 day and let's see how you're doing. Because early intervention is important. We know that if people have a concussion, that they need a period of time to recover. People who have concussive symptoms, who go right back into the game and that stuff, and they don't allow the brain to recover, are more likely to develop more problems over time. So you need to get early help. If after the fact you're saying I've been misdiagnosed wrong, well, then find somebody and go through the whole thing to understand it, because it may be a combination of things. It might be truly from the brain injury or some other stuff, and that's going to direct your treatment.
And don't you find, Harvey, that between the ages of 18 and 22 is an age when psychiatrists say you're most likely to develop a psychosis,
well, that's true.
Schizophrenia, and often that's an age when particularly young men are injured and they get labeled.
Well, no, that's true. Schizophrenia onset is most prominent between about ages 17 and 29. Depression is more prominent from about 35 or 40 into the middle 50s and on. So there's these different mental health type issues. There may be other things. Somebody might develop these neuropsychiatric symptoms in their 60s, and it turns out that they were a player in their 20s, and they housed the spirochetes from syphilis from that point in time, but it didn't become active until they were 60 years old, Or there was actually a great TV show about that once, about a woman who was having all these problems, and I forget what the show was, but they discovered this is what it was, and the son says, "Mother, how could you? I thought you said Dad was the only person you loved." "Yeah, but I didn't say he was the only person I had sex with." So.
Which segues right into the next question, which is for Bud, but I think it's going to be handled by both of them. The sexual side effects and ways to combat this. Well, you don't want to combat sex. We're all sexual beings, so have at it, both of you.
Well, I'll defer to you on this.
Well, everything I learned about this, I learned from Bud, so. Biology is important, and if it wasn't for sexuality, none of us would be here right now. Well, maybe some of the other species in the world would appreciate that right now with climate change. But it becomes one of these things that is so vital and so important, and we deal with it, yet there's so many social mores, especially in this country. In some other countries, it's not as much of an issue. But in our country, we tend to be overly uptight about it. So, people talk to me, "Hey, Harvey, I want to get laid," or blah, blah, blah. Well, okay. "Dr. Jacobs, I want to get laid." "Oh, well, let's see." And I've got to go through my list. What's my malpractice insurance going to say about this? No, seriously, we run into these things. And we also run into things with other attitudes where we deal with sexual predators and things like that. So it becomes much more complicated than it needs to do. There's 3 things that people need in life, with or without a brain injury. Everybody needs somewhere to live, someone to love and be loved by, and something of personal interest and community value to do. And if you solve those things, most people can be fairly successful. And I think that the issues with intimacy get even more difficult because it's not an intellectual exercise. It's a logical thing, but the logical aspects of intimacy transcend our intellectual capacity. And when you're dealing with people's likes, you're dealing with people's biases, you're dealing with people's beliefs, and in intimacy you have the right to say, you know, your nose looks crooked and you're not sexy to me. Well, you can't say that in life, or I like this or I like that. And it's one of the most vulnerable aspects, and people get hurt. We all get hurt in those things, and dealing with those delicate factors. We have to deal with the protection. So I think that's what makes it much more difficult to do. Many people talk to me about that they feel like they're damaged goods, that someone of their sexual preference, because it's not just about heterosexuality, it's just about any sexuality, but someone of their sexual preference doesn't find them attractive or productive or to be a mate. And how do you deal with those things? You have to be open. I mean, when I have these discussions, when I'm working with individuals in my role, and you know, I don't treat patients. I've never treated a patient in my life. I've always worked with people. But when I'm collaborating with a client, and we talk about these things, we can talk about these things frankly. And we can talk about alternatives of what they can do. I mean, if they're looking for physical stimulation or physical release, well, there's a lot of ways to deal with that. But that's not intimacy. And a lot of times the issue about sexuality is really about intimacy. I want someone I can talk to. I want someone that I can cry, or I can just be a jerk, or I can be a bitch at times, or I can just share things with, or somebody who can look into my eyes and know. And that's just a really hard, tough struggle. It's about finding places where people can find others. I'm working with somebody now who, I'll mix it up a little bit, but you know, this person is advanced middle age, not old age, and decided, I want somebody. Well, this person decided they're going to start going to bars. Well, the person has some seizure disorders and some other types of things. And this person was active until their early 20s when they had a brain injury. Well, in your early 20s, going to a bar is a pretty good way to find somebody. But when you're 50 or 60, it doesn't work. And so, you know, and the family won't even let this person go on the internet. Well, no, not for porn, but on dating sites. And part of it is understood because this person has some problems with social awareness and is going to end up being a victim, could very easily be victimized. But the thing is this person needs to learn new skills. So the first thing going in there, I said, you're absolutely right. You have every right to have a friendship. You have every right to have a love. It's a jungle out there, and we all get hurt, and we've all got those things. But it's about, this is going to take time. It's not about going to a bar. So it's about activities. And so someone says, oh, well, at this program, we have a photography group, and this person go to the photography group. Well, what if they don't like photography? You know, or can go to church? Well, that's fine. You know, there's a lot of things happen at, you know, religious organizations. I mean, supporting people to meet each other and to do these things, and that can be good. But it's sort of like the provider's focus is sort of like, I got to get this person doing something. And no, you've got to collaborate with this person to be someplace where they can just be with people and see what develops. And for the person is that this is wonderful that in your, you know, mid-50s you want this again, but you just can't order it like a pizza, unless you're in Nevada, I guess. But it's going to take some time, and it's going to take some developmental skills, and it's going to take, you know, most of these things develop incidentally, especially if you want true intimacy. If you want a sexual experience, that's a different thing. But if you want true intimacy, it's going to develop incidentally, and how to do that and work. And it's going to take time. And this person, you know, has been in a clubhouse program, and the clubhouse says, oh, well, we give this person a calendar every week of all the social events going on. Well, the person has problems with initiation and organization. So we're putting together something for this person to work with somebody of their own gender, to talk about some issues of sexuality, and to take the shame out and to breed past issues. We're also going to bring a mentor into this situation, a companion, to go out with this person, to hang out with this person, to go to different places because the person can't initiate. And the person will say, oh, I don't want to go to this place because it's dumb, or this one's stupid, or yeah, there's nobody there I like. And about half of the time, it's because this person is afraid and they don't know what to do. It's one thing to say, I want to meet somebody. It's another thing to really do it. So this person needs some help that way and to work on these things over time. So let me wrap it up. I'm sort of getting a little tangential, but I think this is one of the most important things. I wish our culture was a bit different to work on this more openly. I think that the right is there. The issue with risk is how do you manage risk of that? How do you manage the dignity? And it's not only for the individual with the brain injury or the disability, but it's for the people who they may be interacting with. And this goes for anybody, but you're interacting with, because I don't care whether you have a brain injury or not. Seeking intimacy and sustaining intimacy are very vulnerable, volatile, but very wonderful things for other people. So I just think it remains a work in progress.
Bud, since you are clinically in a facility managing long-term care, obviously this is an issue that you all deal with. Mm-hmm. Do you have any suggestions?
Obviously, it's difficult in a facility type of environment where things are so structured. We're a community inclusive program. We have 43 beds, and all 43 residents are in and out of their community on a daily basis. We want them to be included. We encourage them to be included. We actually set up situations where they have an opportunity to be included and then leave it to them to include themselves or not. Some of this involves having relationships with members of the opposite sex or of the same sex, whatever their preference. We're not quite as enlightened as we perhaps should be. And that has to do with primarily our ownership and what they're willing to allow. But we encourage every one of our residents to seek out, find individuals that they enjoy being with, and to share with those individuals. And that could be literally on any level. We do have some individuals who actually, before they were injured, had a spouse or had a significant other. And we will always make accommodations when they come to visit, so they have their own personal and their own private time. It is difficult in our environment, but we try to accommodate as best we possibly can.
I want to add one thing. I talked about Nevada a minute ago, but I actually talked with a rehab firm about setting up a program in Nevada. And it wasn't just so that people can have physical sex, but it was for people to develop intimacy. And the company thought about it for a while, and they decided not to. But it's interesting because when I've talked about that, after I include that in a talk, I get a line of family members, mainly mothers, talking about their sons that said if there was a program, I'd have my son there in a heartbeat. And it's not just to have sex, but it's just to have a sense of feeling, accomplishment, and intimacy.
The next question is for Harvey. My son does not show much emotion, and this is really common.
And I actually talked to somebody about this during the break. A lack of showing emotion can occur for many different reasons. Some people just don't feel emotion. A number of people feel emotion, but they can't express it. So they may feel happiness, sadness, all the different emotions, but it comes out sort of bland. And I've seen that affect marriages a lot. When I'm talking to this person before, I talked about this gentleman who had a brain injury from an industrial accident. They had a bunch of kids and everything, and he was actually involved in a clubhouse program, and he wanted to work in the kitchen unit. Well, why? And he said, well, you know, my wife has to work now, and I want, when she comes home, that I can make meals for her and take care of the kids. He was a really sweet guy. When there were other people at the program who were having trouble, especially emotionally, in his non-emotional way, he'd take care of people, and I understand this, and he was really well regarded, but he couldn't express himself. And ultimately, and the wife was wonderful. They'd been married, they loved each other very much, but the marriage failed because of this lack of emotion. He could say, I love you, and he could mean it, or he could do these things, but it didn't come out. And in those types of situations, it's about learning a new language where that's possible. Just like the cartoon I showed with the flare going off over the house, boosh, because Joe couldn't recognize when his wife needed help. So it becomes different, and this is about the change of everybody's behavior, about whoever the significant other is or the friend or whatever, understanding that if someone says, I love you, it means, I love you, or, well, the good news to that is when someone says, I'm angry, plates aren't flying. Sometimes it's an issue of affect recognition where the person just doesn't recognize situations, so they're not perceiving them. So I think it's a large issue. It affects a lot of people. It's trying to develop a communication pattern where that's possible, and trying to work and find out, are you feeling something or not? And for the other person, especially if it's an intimate relationship, whether it be with significant other, a spouse or family member or whatever, it's about what's important to the other family member as well, and can you come to a common bond, or is that going to be an issue that's going to affect that relationship? On the opposite side of that, in terms of not understanding emotional relationships and all that stuff, had somebody else, she was newly married, they were in the honeymoon, husband was driving the car, he wasn't hurt, she had a severe brain injury. And so she's in the hospital, and he was gone someplace. I mean, he had been involved in everything, but he was coming to see her for the first time after she moved to this hospital. And the social worker is very concerned because when asked, the woman says, oh no, I'm not married, because she had retrograde amnesia, so she remembered being single and all that stuff. And so, as staff can get, boy, did we whip it up among us, oh my goodness, the husband is going to feel so guilty, and he's going to walk in, and she's going to reject him because she doesn't know him, and, we talk about, building up a lather. I mean, appropriately so, but I mean, it wasn't, we would just do it in the coffee room or whatever, in team conference. And so, well, the husband was coming in that afternoon, and so everybody was ready to deal with stuff about his rejection and everything. And he walks into the room where she is, and she sits up in bed and grabs him. And someone says, well, who is that? She said, silly, that's my husband. We just got married. So while she didn't have the verbal memory, of that, she had the memory of the moment. And it was like, phew.
Okay, the next question is for Bud. Since he talked about the importance of nutrition, the question is, do sugar and carbohydrates affect the brain, and how?
Well, sugar and carbohydrates. There's some interesting literature out there, some of it coming from Dr. David Perlmutter, who is basically saying that sugar is a poison for all intensive purposes, that high levels of carbohydrates are not good for the brain, not good for the body as a whole, and that they should be moderated considerably. I don't know of anyone in the field who thinks that high levels of carbohydrates and high levels of sugars are good. You need an appropriate balanced level of proteins and sugars and carbohydrates. And carbohydrates and sugars are interchangeable. One's just a more complex version of the other. Some of it has to do with how cells react to it and how detrimental sugars can be. It can also overly stim brain processing. The communication between neurons, high sugar environments can be very detrimental. Generally speaking, people with brain injuries and people without brain injuries as a whole need very similar dietary plans. We need to eat balanced meals. We need to eat smaller amounts than most of us generally eat. And we truly do need to stay farther away from the sugar products and away from the carbohydrate products.
The old standby, don't let your kid eat all the Halloween candy because there'll be a mess the next day.
Exactly.
Yeah. The next question is for Harvey. Should you acknowledge bad behavior? My take from the presentation is not to punish. How do you be sure they realize it is wrong and was told once you wouldn't put up with that in a child, so you should not with a TBI person? It's
not about not acknowledging ineffective behavior. It's it's about taking a look at the whole situation. So if there's dysfunctional behavior or problem that's going on, if you have good communication with somebody, it's about talking about that, but trying to remove some of the shame and emotion. I really don't like that, you know, when you touch me in that way, or so on and so forth. But it's also then saying, well, what are the alternatives and what's going on, and to understand why this thing's occurring. Is it occurring because somebody is frustrated and they really can't communicate their needs? Maybe there's something going on with their medication. Maybe it's what you're doing. Maybe it's your approach. So the issue is to take a look at the whole thing. It's not just about the bad behavior or the problem, but to take a look at the context of the situation, what's going on, and to be able to handle the whole situation. You definitely have to. I mean, punishment just means reduction of a behavior, you know, and it doesn't mean shaming a person or making them feel bad. You know, I mean, some punishers can be very aversive. Hey, you loudmouth idiot, shut the hell up. You know, as compared to, gee, I got a headache right now, you know. Well, you know, the first one probably isn't going to get the person to shut the heck up, okay? The second one, if you have a relationship and respectful thing and they know that you have a headache, maybe they'll talk softer. So all punishment means is decreasing the frequency or the intensity of a behavior, and there's many ways to do that. But it's also to know about what works for people and how it works, and combining those types of things.
This is a two-part question, and I really think the first part may be for Bud. Has there been any evidence that medications for TBI victims take for years on end are detrimental to their overall health as they age?
Truthfully, I don't know if they're detrimental overall as they age. Medications have changed so dramatically over the years. They say that the 1990s were really the decade of the brain because they were finally able to develop medications where the molecular structure was small enough so it could cross the blood-brain barrier. And that made a tremendous difference in treatment. But since then, there have been a number of more refined medications. And as a result, a person who is on a medication that was developed perhaps in the early 2000s and has been on it all of these years may benefit from a more modern medication. Even though they're doing well on it, the aspect of being evaluated for something more newer, perhaps that might allow them to be on a lesser amount of the medication. All of these factors should be taken into consideration. On a daily basis, I see amongst our 43 clients, I see one of them who goes to the doctor says, you know, we really should reevaluate the medication that you're on. We have a couple of new options. And that they will set up a trial program to see if they can titrate them down off of one and raise their levels on another to see if they can get the same, if not a better, affect. And as time goes on, the ideal situation would be to get them off of as much medication as possible, but the medication that they're on needs to be the right medication and exactly the right amount. And just because they're on it right now doesn't mean that in 4 or 5 years there isn't something better that's out there.
The second part of this is, I think, more for Harvey. Are there any suggestions you can make which would help motivate a TBI victim whose chief complaint in life is loneliness, but who is extremely difficult to convince they need to get out and meet people because of their fear of interacting in groups? This fear is based on the notion that others find the victim to be stupid, but this person is actually quite charismatic and chatty once you get them out. They just have injury-induced short-term memory issues, so they forget people.
Okay. Let me talk about the medication thing just for a second, go on that. I made up a word a long time ago called neuropsychopharmacology. Well, we talk about psychopharmacology in terms of medications to deal with psychological issues. And neuropsychopharmacology is understanding the brain-behavior relationships. I think that you really have to, as Bud says, you really have to watch the medications carefully, but the biggest challenge that I find is prescribers who truly understand brain injury, behavior, and all those types of things. They're very far and few between. So I see a lot of people going to primary care providers or even neurologists, physiatrists, psychiatrists who understand medications but don't have the experience or training with brain injury. And so you really need to take a look at that stuff. Medications can be extremely beneficial. It's not a yes or no thing. If you can find some medications that can help to stimulate or to substitute for different brain chemicals and that stuff and things. I'm getting a little bit tired today. I'm so losing my word finding skills. But if you can find some stuff to deal with it, that's fine. I remember talking with a mother many years ago. Had a son, 7 years old, post brain injury, who was jumping off roofs and things like that. And she said, I'm trying to do this all natural and not put my son on any medications. And I said, well, when your son got injured, he fell and hit his head. I understand that. What if your son had fallen on his abdomen instead and it had destroyed his pancreas? Would you deny him insulin because his body couldn't produce insulin? She said, no. I said, well, he fell on his head. And his neurotransmitters and the receptors in the head are being affected. So what we're looking at, if we can find the right type of person, is a good neuropsychopharmacologist, whatever type, physician or prescriber it might be, because there's not a practice of that per se, or a discipline of that, who can try to stimulate those types of things to restore that balance. And if you can find that, I think that works really well. In terms of this other issue of a lack of self-esteem and that stuff, it's really hard. I think on a lot of these issues, it's about a collaborative approach. I mean, a lot of times I'll tell people you can lead a horse to water, but you can't make it drink. But you can feed the horse salty peanuts. And I think it's, if you can't approach the issue directly, can you approach it indirectly? My dad had brain tumors, and he was disabled for many years. And I remember in Florida, Delray Beach, before he passed away, my brother, sister, and I and mother were here. He lived in Kings Point and all that stuff, and we had some cousins and that stuff in Fort Lauderdale. And he would go to see family members, but he wouldn't see anybody else. So we went and saw cousin Bubsy, and that was fine. And we stayed a long time, and we're on the way back, and we're all hungry. We stayed too long. It was going to be a while before we got back, to Delray Beach. And so my wife at the time said something about being hungry, and my brother, yeah, my sister, yeah, my father, we'll be home in time, and blah, blah, blah. And then my mother, bless her soul, said, yeah, I'm hungry too. And, we'll be home. Well, let's try this restaurant. And he looks at her, Reva! It was sort of like, she was the last bastion. She would always protect him, So we went into this restaurant, and he knew that he had been had. He was a smart man. And so we went to the back of the restaurant, and we went at a place where he felt comfortable sitting. It was a round table and all that stuff. And we had dinner, and he suffered through the thing, but then he realized it wasn't that bad. And after that, he'd go out and eat again. We found that one moment, and he was with family, and we did these things, and we didn't go to Lone Star when it's really busy and all that stuff. And so we were able to get through that. And after he did that, he saw that it wasn't that bad of a thing, and he would go out and do those types of things. So I think you've got to find those moments. You've got to try to create those things. And if you can't address them head on, which a lot of times you can't, whether you're trying to work with someone with disability who has a self-image problem, or this other person I talked about in their 50s who decided that they want to find a mate right now, you try this indirect approach, and you try the salty peanuts. You're honest about it while you're doing it. I saw this article recently with behavior modification being used where you could deceive people using behavior modification. It would be okay. It was actually done at a major TBI program. And it's like, no, that's not what it's about. It's about being honest. And, sometimes we get our ways in life and sometimes we can't. And if you can be gentle and dignified about it and provide support, then maybe people are comfortable, or when they find themselves in a situation, they find people around them care and love about them, and it'll be okay.
And sometimes that can start in a support group. Mm-hmm. And some of the support groups do have social activities as an adjunct to their support groups.
There's two types of support groups. There are supportive problem-solving groups, where people find problems and issues, but then they find ways to deal with them. And then there are problem identification support groups. And this is where people go, with support groups. Because what you do is you go in there and a bunch of people who've been there forever.
Complain.
And they complain and they commiserate with each other. And anybody know a doctor? Well, you don't want to go to this doctor because so-and-so. Yeah, he's just as bad as so-and-so and blah, blah, blah.
Those are deadly.
And those are deadly. And those give support groups a bad name. But when you can find a supportive problem-solving group, you know, which, okay, so you got lemons. Hey, I got some sugar and we're going to make lemonade. Those are extremely valuable.
This is a very pertinent question that I hear all the time. There seems to be a tremendous shortage of facilities equipped to handle TBI victims who can care for themselves but struggle with self-isolation and need social structure and support in a day-to-day living environment. Moreover, those which exist have extreme financial barriers to entry. How do families find and afford this kind of long-term care? What resources are out there which we may not be aware of?
Want me to go first?
Sure, go ahead. I'll pick up the pieces here.
Call Bud. I think that, first of all, if a person does need a residential program, you can talk about it, they're extremely expensive. You have high staffing needs, if people need one-on-one care or small group care, structured environments, liability issues, because if you're running a business, you're dealing with legal issues and stuff like that. So there's no simple answer to that. I think that for people who need those programs, they are what they are. I mean, most of the programs that are available today are private, you know, industry programs and stuff like that, and they vary in their costs, and they're not cheap. As a life care planner, I run into that a lot when costing out some of these things. I think that a number of people don't need that level, but they need more in community supports.
Right.
And different states at different times have been doing some wonderful things. What can you do? Well, you can band together as families. I mean, the issues, brain injury is a leading cause of death and disability in this nation, and we can go through all the statistics, you know, and all those types of things. But one of the issues has been families and people with brain injury, we've never been able to come together as a group to push some of the issues as in some other disability areas. And it's about coming together. A number of these things are about politics. A number of these things are about funding and how to activate those things. And we're in different and difficult economic times and that stuff, but it's about the value. It's about what this not only brings to the individual or to others. And I see a lot of that work going on. But if we can create these social support networks, I think that we can help some of these things going on. What's the definition of insanity? There's two of them. You keep doing the same thing over, hoping for something else, or you keep knocking on the same door over and over, and they keep giving you the same answer, and you hope they give you a different answer. The only way you can change those answers is by getting together and getting active and being effective in lobbying as compared to asking for permission. It's about creating a collaboration.
What I would add to it, and I'm not here to promote the program that I come from, although I will say this, we are very unique. We have a continuum of 8 programs that goes from very significant people with very significant cognitive and physical disability up to a level of living independently in the community with support services available 24/7 and a guaranteed number of hours per week at a minimum. But what I find most frustrating in finding programs, and it's the way state waivers are set up. Brain injury doesn't seem to have a clear identity in most states that have waivers. They're either part of the developmental disability side, and they go through their funding streams, and in turn they're regulated in part by the regulation that regulates developmental disabilities. Or on the other side, it falls into behavioral health. And people are trained differently in developmental disabilities, they're trained differently in behavioral health. People who are serving people with brain injuries need to understand what brain injury is. In New Hampshire, we are under developmental disabilities, and we have 10 area agencies. These 10 area agencies are charged with managing the cases of people with brain injuries, a very small minority, about 204, I think, on the waiver presently. Over 4,000 on the developmental disability side, and then another 120 who are in the forensic side for sexual offenses. Now, how do you take a case manager and train them in all three of these areas and expect top quality? If you take a look at the 7 brain injury providers in the state, and we all do things a bit differently, we refer to each other, we communicate, and there's actually very little, what's the word? We don't compete with each other. We know how many beds there are available in the state at any point in time, and we try very hard to work together. The outlier is the waiver system, and it's because they don't understand what brain injury is and what brain injury needs are. And that's in part why you don't see too many programs out there that are able to flourish and stay in business.
Amen. We just have time for one more question. I tried to find one more general than individualized. Psychological maturity stops at the time of injury. Really? That's you.
No.
That's great.
No, you continue to mature over your life. What happens sometimes with some of the referrals I get on behavioral issues is people may be reacting to things like they did, prior to their injury. The rate that you develop, your sense of insight or things like that may change over time. But people continue to change and grow over time. We talk about, you've got 2 years after injury until you plateau. I don't think that that's the case. I think there's a lot of changes and things go much more slowly then, and you got some ideas. There are times when people have frontal lobe damage or things like that, so they have problems with judgment, reasoning and that stuff, where they're not able to develop new skills. So they rely more on their premorbid skills, but that doesn't mean that they're not learning and developing in other ways. So that may be a marker for some people, but I don't think it's an absolute sentence at all.
If I could just add to that.
Yes.
What I was reporting on, and on that topic in particular, I was reporting on the findings from 3 different authors who work in brain injury. When I read it, I was surprised. In my experience, individuals continue to grow, and they continue to grow until death, is the way I've always observed it. They may not grow in these great leaps, but they will grow in these tiny little steps, but they continue to grow. They may plateau, and then they will move forward again. If they regress, I often see it's because of some external problem, such as a medical condition or something psychosocial that's going on. But people continue to get better. And I think that's one of the major fallacies in brain injury, is that people don't believe that, but they do. They get better.
It used to be what you see in a year, that's it, that's all you get.
Oh, I remember.
Or 6
Sure.
months sometimes. So